السلام عليكم ورحمة الله وبركاته. Good morning everybody. It's Friday. اللهم صل وسلم على عبدك ورسولك محمد صلى الله عليه وسلم. I'd like to thank the scientific committee and the organizer for their invitations. Today I'm going to present pediatric registry through the lens of juvenile idiopathic arthritis. I think you would agree with me that rheumatological diseases in general is very rare disease in community and probably does not receive full attention similar to other diseases. I hope I'll get my slides. Okay, thank you. I have nothing to disclose. These are the outlines of my presentations. And in general, as I said, rheumatological diseases are rare in community and probably they didn't receive the deserved attention that they deserved. And the availability of data are limited. And that limits the availability of high impact studies that we can, based on that, our decision when we treat our patient, and it will affect the impact of or have implications in treating patients. The first registry attempt was the CARA registries, or what's being called CARA Legacy Registry. They started in 2009, a 5 years registry. They limited by 5 years because their NIH fund was only for 5 years, which was concluded in 2014. And during the first 2 years of the study, they had 11 studies which were published from that registry, and 16 abstracts were presented. Subsequently, based on their successful experience with the first registry, they planned for a second registry that's 10 years registry, aiming to include 10,000 patients of various rheumatic conditions, including juvenile idiopathic arthritis, JDM, systemic lupus, and scleroderma. And the aim of the study to be extended over 10 years. It will be included in 2025, and it will provide longitudinal studies about all those patients. So if we think about juvenile idiopathic arthritis, it's the most common disease among our diseases, and it might be surprising for general people if you tell them that it's as common as type 1 diabetes mellitus, but unfortunately they didn't receive the same attention. So despite that, current understanding of pathogenesis, natural history, and long-term outcome is still limited in many countries, including Saudi Arabia, for juvenile idiopathic arthritis. So the aim of registry is to trying to establish a surveillance tool that facilitate exploring GI in Saudi patients. Objective of the registry to provide comprehensive updated information, epidemiological demographic of JIA at National Guard hospitals, and to explore early ongoing management as well as disease outcome, hopefully sometimes later. So when it comes to the method, we started in August 2021 to collect retrospectively the data for juvenile idiopathic arthritis patient that's been diagnosed in National Guard facilities through electronic records. We have electronic records called Best Care, and all patients were included. Using grid cap to fill up the variables for a patient with juvenile idiopathic arthritis, we collected the socio-demographic data, clinical presentations, laboratory tests, radiological studies, and therapeutic medications. Data is collected and updated every 6 months. So I'll share with you today preliminary results, as this work is still ongoing work. So by August 2023, we have 223 patients of JIA that's been entered into the red cap, and around 60% of them were female, which is not surprising. Median age is 8 plus minus 1.8 standard deviation. So when we see the distribution of patients that they're attending to our clinical service across the kingdom, most of our patients is from central region, around 82% of the patients from central regions, and that might indicate the catchment for National Guard patients. However, we still have some patients from Eastern and Western province as well to some extent or lower extent, the northern part of the kingdom and also southern part of the kingdom. The JIA classification, oligoarticular JIA stands the most common category that we've seen, and I think that's consistent with all other published literatures and finding anywhere else. Systemic JIA is the second, and as you know, sometimes you'll find that poly-JIA is reported as second category, followed by polyarticular JIA. Some laboratory finding, I think I'm giving you short examples of things that's been reported so far. So ANA found positive in 58%, negative in 58% and positive in only 34%. Some patients are missing ANA that wasn't done, which is might indicate that probably in our practice we have to standardize our approach for investigation patient with JIA. HLA-B27 positivity is quite low, 3%, and that might not be surprising if we know that in our general population, in general, HLA-B27 is low as well. So biological medications, if you see that systemic JIA and poly-JIA, almost 100% or nearly 100% of the patient, they had been treated with biologic therapy. That indicates probably we are providing our patient with the standard of care, because probably these are the two subcategories of disease that you need to be aggressive with them from the beginning and attempt to utilize the window of opportunity. So what are the challenges that we face with this registry, and might be fair to share it with people? I think having data from a single center might limit the utility of these data, and hoping that we can broaden this experience in the future. Collecting data does not include biological sampling, which might help in studying the disease pathogenesis at cellular level, and hoping in future we might see this and how would it have implications in the treatment that we used. We thought that calling for national registry, starting off with JIA and probably generalizing the experience across the board for other rheumatological diseases, might be something that people need to consider in the future. And I think with our group, Dr. Hindel Gouei and the colleagues in research committee, we try to discuss this and hoping that society can support us in this direction. So in general, rheumatological diseases are rare diseases, and what limits the accessibility to the epidemiological data and also the experience that people share is availability of data. We hope that the registry can serve as a valuable paradigm for studying these uncommon diseases, and we could share the experience in the future at a national level. So these are some references that we use in our presentations. And I'd like to take this opportunity to thank our team in KASH, Dr. Wafat Sweri, Dr. Abdulrahman Rashid, Dr. Jude Al-Masoud, and Dr. Abdullah Mjalli for their great support, and also public health section at KMARC for their support from logistic point of view. Thank you so much.
Thank you very much, Dr. Gibran, for this overview. Any questions?
Thank you, Dr. Gibran. Just a small comment, not question. The registry for Saudi Society for Rheumatology already established. I mean, the infrastructure, Dr. Hind, Dr. Mitaba, Dr. Arima, and myself, already we made the template and everything is there. It's a matter of the project. It's a matter of waiting for the grant from the society to start. So I think it's ready for you to start, and hopefully, inshallah, we'll see soon.
Great, that's a good news, and the level of information that we reached to, that they collected the variables, but when they asked for the grant, it wasn't supported at the beginning. So I think it's a great idea to share, because one of the good things that we have done in this, and I think this is probably something that people always need to exchange and share, we ask international experts to review the variables for REDCap. So I think probably looking at the variables that we are collecting, beforehand will provide us with great insight what are the essential variables that will help us in the future, down the road. Because one of the things that we haven't included in the result yet, and we are still working with it, is the outcome measure. I think including outcome measure in such registries will be really a great tool in the future.
Thank you very much. Are you ready?
Thank you.
So we go back to Dr. Alujain's abstract on the efficacy and safety of growth hormone in childhood SLE, a systematic review.
No, it's okay. Okay, Bismillah. So I'd like to thank the abstract committee for accepting our poster. So I'll be presenting it on behalf of the team. The efficacy and safety of growth hormone therapy in childhood SLE. So as a background, we know that childhood lupus have long-term consequences. So the survival rates have improved. We have talked about that yesterday. Owing to the advances in the management. This was coupled with the uncovering of the long-term complications, including the growth delay up to 30% of population. And there was a study by Prof. Mayouf and adult colleagues in Saudi Arabia, up to 50% of patients will have growth delay and short stature. So contributing factors could be due to modifiable and non-modifiable factors. The modifiable factors include the glucocorticoid doses, disease activity control. Non-modifiable factors will include the gender, like male gender, lupus nephritis, and the disease severity and age of onset. Now, possible therapeutic intervention, we know that in short stature is growth hormone therapy. So patients with childhood lupus are not different. They do need physical and psychological support, including the short stature therapy. However, there's a special consideration in childhood lupus, the bidirectional relationship between lupus and growth hormone. So first, SLE by itself can suppress the growth hormone axis, which leads to growth hormone deficiency and short stature. On the other hand, the growth hormone itself was found recently to play some role in the etiopathogenesis and severity of the disease. So the aim was to evaluate the current evidence of the efficacy and safety of growth hormone in childhood SLE. Now, the search methodology was based on the PRISMA guidelines. The search was conducted last year, September and October, of the studies from January 1988 to October 2023. And we chose that duration because the studies in growth hormone therapy and rheumatic diseases was around that time in GIA initially. So we searched the electronic databases, including PubMed, Cochrane Library, and Web of Science. We included all articles in English, all children or pediatric patients with SLE who were treated with growth hormone at any dose with or without growth hormone therapy. So because of the limited or expected limited data, we included all case reports, series, cross-sectional studies, cohorts, and reviews. However, we excluded viewpoint articles and incomplete articles or non-English literature. So the search terms or MISH terms included anything that will indicate childhood lupus or pediatric SLE or juvenile SLE, as well as growth hormone therapy trade name, scientific name, or any MISH term for growth hormone therapy. So two independent reviewers screened initially the studies by the title and then by the abstract. Then full text of the citations were examined by both reviewers. Any disagreements regarding the eligibility was solved by another third reviewer. So full text articles were screened, and further, references list of the primary articles were searched for additional studies in these references. Moving to the results, so we identified initially 8,191 records from those three databases. Out of which 1,800 plus were excluded or removed due to duplications. And we screened initially by the, as I mentioned, title, then abstract, 6,364 articles. Out of these articles, we excluded 6,343 articles due to irrelevance, wrong population, drug, no intervention with growth hormone therapy. We ended up with 21 articles for retrieval. Out of those, we could not retrieve one article because it was an old study for a single author. It was case report. We tried to reach that author, but there is no response. The other was in Portuguese, so it was excluded. So we ended up with 19 reports eligible for the full assessment, and out of those, we excluded 12 due to no treatment, wrong medication, and wrong population. So we started with 8,000 plus, we cut it down to 6,000 plus, and then 19 reports were assessed for eligibility. Out of those, ultimately, we ended up with only 2 articles that were eligible for the study. So these were only case reports, long time ago. So one was from Korea, 2001, the other was from Singapore, 1998, so this was 2 decades back. Both were males diagnosed at the age of 8 years with SLE. Both had lupus nephritis wearing prolonged duration of glucocorticoid, and that is why they thought that they had short stature due to disease activity itself and due to the glucocorticoids. One of them, the first patient, had growth hormone deficiency with low testosterone. So the age at initiation was 16 and 15 years respectively. The height after growth hormone improved significantly. We're talking about 10 cm within 9 months and 2.7 cm within 4 months. However, the growth hormone therapy was discontinued because they had the flare manifestations. Both patients did not have clinical features. Both of them only had serological manifestations, and at that time there was no explanation for the flare other than growth hormone therapy, but this cannot be proven. Now, therapy escalation was required in one patient, the first patient. As you can see, there was increased dose of glucocorticoid and shortened cyclophosphamide intervals. Unfortunately, other side effects reported in growth hormone were not mentioned in these articles. So both concluded that there is a positive effect or potentially positive effect of growth hormone in childhood lupus. However, it might increase disease activity. Again, we cannot conclude that. So our study concluded that growth failure and short stature are known as potentially irreversible complication of childhood SLE, and patients do need a therapy. We are not giving them therapy because of the severity of the disease, but we cannot still ignore that aspect. So this systematic review demonstrates the limited data. We did expect limited data, but not to the extent of 2 case reports 2 decades back only, and there's a gap after that. Reports in this study described a positive effect on linear growth, but with lupus flare, again, we cannot prove any of those with case reports. Further studies and clinical trials are needed to better understand the potential efficacy and safety of growth hormone therapy in childhood SLE, including different aspects. We do have some limitations in this study. So first, the language selection. There was one Portuguese study that we excluded, which also added to the limited number of data. The second limitation was the study publication and type. So again, these are 2 decades back and only case report. We cannot come up with solid and definitive conclusion for either the role of growth hormone therapy in the flare or the improvement in height. So there is a potential side effect of growth hormone therapy which has not been mentioned in these articles, metabolic side effects or other mentioned side effects on bone. Unmet needs in growth hormone therapy in childhood lupus. We do have some pre-therapy consideration, therapy-related, and long-term consequences. So pre-therapy consideration is the what is the optimal age for therapy initiation? Still, we do not know that. Second is there an accepted disease severity and activity before we initiate growth hormone therapy? Should we put patients in remission or disease activity? Still, there is no answer. And what is the accepted dose of glucocorticoid and lupus therapeutic, knowing that glucocorticoid will affect the bone metabolism and growth? The second is the therapy related. So what is the optimal dose and duration to continue growth hormone therapy? And will therapeutic interventions directed for SLE affect the response for growth hormone therapy? We know that the pathway of growth hormone therapy do interact with some of the medications that we're using. The third question is there a potential of growth hormone therapy counteracting our medications which will induce flares in lupus? And the final point, which is the monitoring and long-term consequences. So what should be the frequency to monitor patients for the clinical and serological activity? Should it be more frequent while we start growth hormone therapy or not? Second, are there any additional metabolic effect that has been reported, glycemic control, bone formation and resorption, especially that these patients are on glucocorticoids? And the final question is, what is the expected final adult height that we should be satisfied with? Is it the same as the normal population, or is it different for patients with lupus? And by that, I would like to conclude. Of course, I would like to thank the team for their amazing job. These are medical interns that did amazing work, and of course, Prof. Al-Mayouf for his continuous support throughout. Thank you very much.
Thank you very much, Dr. Alajain. Any questions?
Yes. Well, this is another idea, yes, but we limited that to SLE because of the deficiency that was expected. So GIA, there are studies in GIA, a huge amount of patients, not randomized control, not strong evidence to be honest. All of them are case report, case series. But we think that the deficiency is more in lupus patients, and we know that these patients up to third will have short stature. But somehow we're ignoring that part because of the disease severity. So I think it's time to assess that medication efficacy and safety in lupus.
Thank you, Dr. Alajain. We'll move on to our last abstract. Practice, patterns, and approach to childhood lupus nephritis in Saudi Arabia, presented by Dr. Amtina.
Assalamu alaikum warahmatullahi wabarakatuh. I would like to introduce our project, Practice, Pattern and Approach to Childhood Lupus Nephritis in Saudi Arabia. This project done by Dr. Abdulaziz Al-Mutairi, Prof. Sulaiman Al-Mayouf, Prof. Jamila Gari, Dr. Muhammad Nishawi, and myself. I have nothing to disclose. As we all know, renal complication is a major cause of morbidity in SLE, and this is more prevalent in pediatric patients, including our population. However, a variation in the management of these patients had been observed between the pediatric rheumatologist and nephrologist. So our objective is to review the current physician practice and in diagnosis, management, and monitoring of childhood lupus in Saudi Arabia, observing variation similarity to international guidelines and limitation. We designed multiple questions with different clinical scenarios covering more than one aspect regarding childhood lupus nephritis. We did not include question about hydroxychloroquine, as this is the standard of practice, as well as multi-target therapy and other points. The questionnaire was divided into 4 domains, but for the sake of the time, I will mainly focus on the important result regarding general and demographic information, proliferative lupus, the management of proliferative lupus nephritis, and adjuvant therapy. Among 135 physicians, we have response for more than 40% of them. 33 were nephrologists and 28 were rheumatologists. Regarding the steroid use in the induction management of the proliferative lupus nephritis, 70% will use pulse steroid followed by an oral steroid, 2 milligram per kg. 50% will start with only oral steroid, and the other 15% will use other regimens. So when it comes to the weaning of steroid after partial or complete response, 18% will stop after 3 months, 30% will stop after 6 months, and the majority will continue on low-dose steroid for longer duration. So regarding the choice of immune suppressive medication during the induction treatment, there is a variation among the respondents. 46% will use cyclophosphamide, and the majority will follow the NIH protocol. 35% will use MMF, 10% will use rituximab, and 3% will use calcinuria inhibitors. When we went back to the result, we found that the majority of rheumatologists in the red color will use the cyclophosphamide, and the majority of nephrologists will prefer to use the MMF. As expected, MMF is the drug of choice regarding the maintenance treatment. So remarkably, only 10% will use rituximab as a first-line treatment. 34% will use rituximab as a second-line treatment. There is no agreement regarding the time of discontinuation of the immune suppressive medication. However, 33% will stop after 3 years, 40% will stop in earlier point, and 25% will continue for more than 3 years. Regarding the adjuvant therapy, 90% will use angiotensin-converting enzyme agent to control the proteinuria, and if cyclophosphamide was used in the treatment regimen, only 33% will use BGB prophylaxis. For girls who are post-menarche, 30% will use gonadotropin-releasing hormone, 7% will use oral contraceptive pills, and the majority will not use any fertility preservation. Regarding SLE disease activity monitoring, 41% will use the SLE disease activity index, and most of them are rheumatologists. In conclusion, the results of our study show considerable difference and individual variation in the management of childhood lupus nephritis in Saudi Arabia. It also shows considerable agreement and some differences with international recommendation. This study is already accepted in the Saudi Journal of Kidney Diseases and Transplantation, and will be published online soon, so you can have a look on the complete results. So what I have learned from this study is the importance of collaboration between the pediatric rheumatologists and nephrologists, and the need of national guidelines, national consensus. So me and my team started this project, Consensus for Managing Childhood Lupus Nephritis, in Saudi Arabia, and this project is under the umbrella of Saudi Society for Rheumatology and Saudi Society of Nephrology and Transplantation. And let me briefly introduce you to this ongoing project. The organizing team are Dr. Abdulaziz Al-Matairi, pediatric rheumatologist from King Saud Medical City in Riyadh, Dr. Ibrahim Sandukji, pediatric nephrologist from Taiba University in Medina, Dr. Abdulaziz Ba Hassan, pediatric nephrologist from King Abdulaziz University in Jeddah, Dr. Hana Al-Ahmari, adult rheumatologist and epidemiologist from King Khalid University in Abha, and Dr. Muhammad Nishawi and myself from King Abdulaziz University in Jeddah. Our objective is to develop recommendation of the management of childhood lupus nephritis involving both disciplines, the pediatric rheumatologist as well as the pediatric nephrologist, taking in consideration the different region and health system in our country. So this is our task as an organizing team, and this is what have already been done. Another team will be the expert panelist, and we decided to choose as if they have more than 5 years in rheumatology, nephrology, different region, different health system, and has experience in lupus nephritis as an optional criteria. The rheumatologists and nephrologist experts are demonstrated in this slide as they are practice and work in different regions as well as using different health system. We may consider other as external experts, adult rheumatologists, and adult nephrologists. The plan is to arrange an online meeting between the organizing team and the panelists in April 2025, and we will have multiple voting sessions if needed. This project will be the first project conducted in Saudi Arabia involving both disciplines, and hopefully reaching a consensus will improve the quality of care for our patients. And this concludes our presentation, and thank you for listening.
Thank you very much, Dr. Amtinan. Any question for her? Thank you, Dr.
You're welcome.
دكتورة لجين الأحمدي.
So we'll have a break for 10 minutes, and we'll come back at 10:50.